So let's move on to leukemia. So leukemia is nothing but the presence of blastic cells in the blood. So you can classify leukemia as acute leukemia and chronic leukemia. So acute leukemia is when you see the blast percentage to be more than 20%. So number of blasts should be more than 20%. Okay. So the examples of acute leukemia will be acute lymphoblastic leukemia and then acute myeloid leukemia. Okay. In chronic leukemias, you are not having blast more than 20%. Blast is going to be less than 20% only. And the best examples here will be chronic lymphocytic leukemia and then chronic myeloid leukemia. Okay. So let's see about the risk factors associated with acute leukemia. So in genetic causes, you are going to have various syndromes which are associated with acute leukemia. So when reading about neoplasia also, we were studying about Bloom syndrome, ataxia telangiectasia, and then Fanconi's anemia. So all of this were DNA repair defects associated with homologous recombination, right? So there I mentioned they have an increased risk for developing acute leukemia. So Fanconi's anemia. So these three things are risk factors. Apart from that, Wiskott-Aldrich syndrome. It was an immunodeficiency syndrome, right? Associated with eczema and thrombocytopenia. Wiskott-Aldrich syndrome. Then Down syndrome. So all of this are going to be associated with acute leukemia. Especially in Down syndrome, if they ask, it is ALL, acute lymphoblastic leukemia, which is more common than AML M7. So in acute myeloid leukemia, it is the megakaryocytic type, that is the AML M7, which is common, and this is common in less than 2 years of age, while ALL is overall the most common leukemia in Down syndrome. Then in radiation, if you see ionizing radiation, so ionizing radiations like X-rays, alpha rays, gamma rays, so all of these rays can cause acute myeloid leukemia and then acute leukemia as such, okay. Then chemicals, especially benzene. So these again we were studying about it when we were discussing the neoplasia carcinogenesis, remember. Then apart from that, infections like HTLV1, then Epstein-Barr virus infections and certain drugs also. So drugs like alkylating agents. So these are chemotherapeutic drugs which are given for treating cancer. So you are treating for one cancer and then because of that drug they are developing acute leukemia. That's bad, right? So alkylating agents like cyclophosphamide. Then drugs like topoisomerase 2 inhibitors like etoposide. So these two drugs are actually associated with a specific type of acute leukemia, acute myeloid leukemia, okay, and they can also cause myelodysplastic syndrome. These are related with myelodysplastic syndrome, and this MDS can transform into acute myeloid leukemia. So we'll be seeing that lately now. So other than that, diseases like paroxysmal nocturnal hemoglobinuria, aplastic anemia, MDS, all of this can in turn become acute myeloid leukemia, okay. So PNH, aplastic anemia, these are all stem cell defects. So these can transform into each other, and then they can also become MDS, and MDS can also transform into acute myeloid leukemia. So these are all the risk factors associated with acute leukemias. So let's start with the first type of acute leukemia, which is acute lymphoblastic leukemia. So as the name suggests, there is going to be lymphoblasts, and these lymphoblasts are going to be more than 20%. So in genetics involved in acute ALL is going to be hyperdiploidy, hypodiploidy, trisomy 4, 7 and 10. Apart from that, we have various translocations, especially translocation 4, 11, 12, 21 and 9, 22. So in this, hyperdiploidy is going to be most common and it is having a good prognosis, while this hypodiploidy is going to be associated with bad prognosis. And this translocation 922. So do you remember this? So translocation 922 was also seen in CML. Remember BCR-ABL fusion. So this translocation 922 can happen in ALL as well, and it is going to result in a fusion protein which is of 190 kilodalton. In CML, it was 210 kilodalton. And this translocation 922 can also form another fusion protein which can be of 230 kilodalton. So in CML, this 220 kilodalton fusion protein was actually having a good prognosis because we can treat this by inhibiting this tyrosine kinase inhibitor, imatinib mesylate, while this 190 kilodalton associated with ALL is going to have a bad prognosis, okay. In CML it is good, in ALL it is bad. This 230 kilodalton is going to be associated with increased neutrophilia, okay. So what are the clinical features we see in acute leukemia? So obviously the bone marrow is going to be filled up with the blasts. So the other cells are going to be decreased. So erythroid precursors, then the myeloid precursors, the megakaryocytes are going to be decreased. So when erythroids is decreased, it is going to lead to anemia. When other WBCs, the proper WBCs are not there, it is going to result in infections. Without megakaryocytes, it's resulting in bleeding. Platelets are not formed, resulting in bleeding. Then there can be organomegaly. Then sternal tenderness, specifically in ALL, if you see, it is going to have sternal tenderness because bone marrow is expanding with this blasts. So if you see, ALL can be either a B cell type of ALL or a T cell type of ALL. So under B cell type of ALL, the age group usually affected is going to be around 5 years of age group. While in TALL, it is usually the pubertal adolescent males, pubertal age group, which is going to be affected. So what are the sites involved in BALL? It is usually the bone marrow and the peripheral blood which is being involved. While in TALL, it is the CNS. It can also involve the peripheral blood as such, but it can also have testis, CNS and mediastinal involvement. So when they give a history, they are going to mention it as a mediastinal mass commonly. Okay, so when they mention mediastinal or a testis or a CNS kind of mass, you'll have to think about TALL also. And this is going to have a bad prognosis. All of this CNS, testis and mediastinal involvement is going to have a bad prognosis. So BALL, when will the blast become BALL? When the transcription factors like EBF, PAX5 are being mutated. So that will lead to BALL. While Notch gene mutations will result in TALL. So Notch, already we had seen that Notch is involved in T cell maturation, while PAX5, EBF and E2F are related with the B cell maturation. So in immunohistochemistry, if you see, the BALL is going to be positive for CD10, which is also called as the common ALL antigen. So CALA positive. So CALA is going to be a marker of early precursor B cells, right? So CALA positive will be positive. Then CD19 and 20. So CD19 is the pan B cell marker. So CD19 and 20 will be positive. While in TALL, it is going to be the precursor markers, which is CD1, 2, 5 and 7, which is going to be positive. Okay. Then BALL as such has a good prognosis, while TALL usually is associated with a bad prognosis. So what are the findings which we see in ALL? So obviously in the peripheral blood, if you see and make a peripheral smear, it is going to have lymphoblasts which are more than 20%. You'll have to count the blasts and it will be more than 20%. And if you put a special stain with periodic acid shift, it is going to give a block positivity. In acid phosphatase, if it is a TALL, if it is going to give a polar positivity, which is resistant to the, which is going to be sensitive to the tartrate. And immunophenotype of this, immunophenotype is nothing but the CD markers which we give, right? So how do you define the lymphoma or the leukemia? So that is called as immunophenotype. We check it with flow cytometry. So the immunophenotype of this ALL is going to be TDT positivity. So ALLs are positive for the immature marker. Immature blasts are going to express this TDT positivity. Okay. So the prognostic factors, the good prognostic factors in ALL is the age group between 2 to 10 years of age group. So less than 2 years or more than 10 years, it is going to be associated with bad prognosis. Then a female commonly has a good prognosis. Then the count, if it is the TLC count is less than 1 lakh. Or in FAB classification, previously it was FAB classification. Nowadays we are using the WHO classification only. So previously in the FAB classification, L1 is associated with a good prognosis, while L3, which has multiple vacuoles in it. So lipid vacuoles, so that is associated with a bad prognosis. While WHO, BALL, I already mentioned, has a good prognosis, while TALL has a bad prognosis. And CNS, testis, mediastinal involvement in TALL is having a bad prognosis again. And then coming to the genetics, hyperdiploidy, trisomy 4, 7 and 10 along with the translocation 12, 21 is going to have a good prognosis, while translocation 9, 22 resulting in 190 kilodalton, and then translocation 411 and especially hypodiploidy, all of this is going to have a bad prognosis. So hyper is for good prognosis, hypo is for bad prognosis.